further delay, we'll start the next session, and that's Dr. Mary, please join us. And this is a free paper session on diabetic retinopathy and medical retina. I invite my chairpersons, Dr. Nangia sir, Dr. Jayanta Guha, and Dr. Mary Santosh. I think Dr. Arindam will be joining us soon. Yeah. So the first free paper is by Dr. Moona Bende. Am I right, ma'am? Yeah. So
What's the doubt? Is it Una?
no.
No,
Whether madam is the
else on the list. That's why I got confused.
Yeah.
Yeah.
And madam will be presenting the paper on mRNA and LcRNA signature discovery as potential biomarkers in PCV.
Yeah. Good afternoon. I'll be talking about potential biomarkers for treatment response in PCV. Basically, PCV has a variable presentation starting from chronic CSR to massive subretinal hemorrhage. The treatment responses are variable, often disappointing. And determinants to treatment could be either genetic profile, choroidal morphology, or possible other biomarkers. The genetic associations have been associated with the ARMS2 HTRA1 locus as well as the CFH locus. They tend towards either similarities to ARMD or CSCR. And our understanding of the pachychoroid spectrum tells us that CSCR and PCV could be two ends of the same spectrum when the choroid is thickened. The subtypes based on morphology could be either the RMD end of the spectrum where the choroid is thin, response to anti-VEGF is poorer, is better, and there is an ARMS2 HTRA1 association, whereas typical PCV has a thicker choroid, better response to PDT, and has an association with the CFS gene. So we looked at other biomarkers, more importantly regulatory molecules that could drive our treatment response. MicroRNAs are basically a class of non-coding RNAs important in controlling gene expression via regulation of protein coding genes. They occupy 1 to 5% of the human genome and regulate at least 30% of protein coding genes by either degradation or translation inhibition. And they have been shown as a biomarker and regulatory of disease-causing genes, both in DME and AMD, and as of yesterday, there has been no report on PCV. Similarly, for long non-coding RNAs, they are more than 200 nucleotides long, have no apparent protein coding potential, but they can regulate various biological proteins by chromatin remodeling or protein translation. And they have been recently showed as newer regulators of angiogenesis in retinal neovascularization, including diabetes and ROP. So our research questions was, is it possible to identify PCV disease specific and drug response specific microRNAs and long non-coding RNAs in cases? And could these be used as biomarkers for screening or potential therapeutic targets? This was a pilot study for feasibility. We took 4 cases. One was treatment naive, one was active and unresponsive after 6 monthly injections, one was on PRN maintenance treatment, one was a normal control. For equality, all were females with no major systemic comorbidities. And this was the technique. We isolated RNA from the blood sample, sequenced it to get the small RNA library, and then compared it with the referenced human genome and assessed the known and novel mRNA prediction. And then also we looked for the microRNA and long non-coding RNA sequences and validated with qPCR. And these are housekeeping microRNAs that are formed everywhere in the human genome. What was surprisingly that the biomarker for colorectal cancer was seen in all our cases. The significance is not known. The top right shows you housekeeping microRNA from the LET7 gene, which is seen in all humans. Now coming to known microRNA expression, the treatment naive cases showed a very high tag count of microRNAs known to code for cell migration and proliferation, and as well as a very high tag count of known microRNAs known to be responsive for tumorigenesis. This is the heat map showing the relative tag counts of the various microRNAs. And we found unique microRNA expression in all categories. It was the highest in the treatment naive category. Similarly, we found different long non-coding RNAs from all categories, and this was the overlap Venn diagram. So to conclude, it's the first report proposing the role of microRNA and possibly long non-coding RNA as biomarkers to determine treatment response in PCV. We found differently expressing microRNA and long non-coding RNA in each category, and discovery of novel microRNA is not described so far. Since submitting this paper, we have expanded it. We have now 3 cases in each category. We have found similar differences in expression, and validation is underway. Thank you.
Great concept to lead fantastic. But one or two questions.
Yeah.
Why do you think that the microRNA there was a rise in mRNA over until
That was something surprising that we've seen, but since they're all housekeeping microRNA, maybe it's just a protective mechanism that is seen. And these were only 4 cases, so it's a little difficult to expand. We're validating the other 12 now, so we'll know whether it is similarly seen. Yeah, this is a 1-point assessment, sir. So this is one treatment naive case, one responsive patient. So these probably would be guiding their response. Now what happened to the treatment naive case 6 months down the line, we'll have to see. Yes, we'll have to see.
Okay, thank you, ma'am. The next paper is quantitative and qualitative comparison of wide field OCT angiography and FFA in proliferative DR by Dr. Manpreet Brar. Is Dr. Manpreet here? Okay, so she's absent. So we'll move on to the third paper in the session, and that is Dr. Azhar Mohammed. Is he here? No, he's here. Dr. Yeah, he's there. Are you a AIS member? So, what is your membership? 220? No, that is Dr. Yusuf Sheikh, no? Oh, so, and you're the presenting author? Ah, okay. Sorry. Oh, okay. That's the full name. Oh, okay. Sorry. Okay. I thought Yusuf Sheikh was the second author. So you're going to present on screening for diabetic retinopathy in rural population,
Yes,
role of ASHA workers.
Yes, sir.
Please go ahead.
Good afternoon, everyone. As we know that the tsunami of diabetes has already taken over the globe, and India being the second largest populated country, and 70% of the population is being resided in the rural population. So this rural population cannot, the underserved population cannot be neglected. So we just try to initiative with the help of ASHAs to increase the diabetic retinopathy screening in Wardha district. So basically the present study highlights the role of ASHA in screening for diabetic retinopathy. In this, we have mentioned their role, but many studies have mentioned their role. But this study we have practically intervened with the help of ASHAs for effective screening of diabetic retinopathy. Screening was done with the help of a non-mediatic fundus camera, with the help of trained ophthalmic assistants, and fundus photographs were uploaded on a online software which was further graded by ophthalmic surgeon at the base hospital on ETDRS classification. Patients who needed further management were referred to base hospital. We done the screening part in 2 phases. In phase 1 was done for over the period of 8 months, in which screening at CHC was done without intervention. Intervention was training of the ASHA workers. In first phase there was no intervention. Fixed facility screening was done at CHC, SDH and DH. Remote grading of fundus photograph at base hospital by retina consultant and online reporting. Feedback and referral of DR patients to MJMS for investigation treatment. The registration was done on an online Android-based software, and patient fundus photograph were taken by a non-mediatic fundus camera, and reporting and referral was done on online basis from base hospital. The patient who needed management were referred to base hospital, and respective investigations were done like FFA, OCT, and the patient which needed further like laser treatment or intravitreal was done according to the need of the patient. In phase 2, all the known diabetic patients were line listed by the ASHA worker at the PHC and subcenter level, and this intervention was done over the period of 4 months. Training and orientation was done with the help of structured IC material in local language, that is Marathi and Hindi. Audiovisual posters, leaflet, focus group discussions and peer support group were made. Monthly meeting was done at primary health care center with medical officer and ASHA workers. And similar procedure of consent, registration, demographic detail, and fundus photography and diagnosis with teleophthalmology and management was done as followed in phase 1. These are some posters which were used during the intervention. These are photos of leaflets and pamphlets. These are the photograph of meetings done at various center, and this intervention was done at 4 center initially, and 1 center was without any intervention. So now screening was done with the help of ASHAs at primary health center and sub-centers. The result was 5,400 patients were screened total, and out of which 375 were referred for diabetic retinopathy and 81 patients were treated. Now here you can see the trend of number of diabetic patients screened in different blocks. Now up to August there was a first phase intervention, and as we put up the information in 4 center, in one of the center we didn't done the intervention, and as you can see the number of patients screened over the period of 8 months were similar to number of patients which was done in 4 months, and the intervention was done over a period of 1 month in each block. As you can see the rise, and one Vardha block as example, that's 793 patients were screened over the period of 8 months, but similar 885 was done in next phase. Now this is a trend of screening over the period of year. As you can see the spike as the intervention was done in month of August, September, October. And now this is a cumulative trend of the screening in various blocks, and the last RV there was no intervention done with the help of ASHA, and there was decline in the number of screening. Now, basically, the ASHA, we can say that it is a ray of hope in diabetic care in the rural India, because it can helpful in conducting awareness, raising campaign on diabetes, generally to prevent the onset of diabetes and complication, identifying the cases of diabetes within the community and referring them to diabetic care facility, blood glucose monitoring, motivating expectant mother for blood glucose testing, diet and exercise counseling for the people with diabetes, encouraging regular follow-up to clinic, early detection and complication, and their referral. Now the present study basically highlights the role of trained ASHA in making the annual screening of non-diabetic patients for diabetic retinopathy more effective and robust in the rural population of India. Study emphasized the importance of early screening of diabetic patient for diabetic retinopathy for preventing avoidable blindness due to diabetic retinopathy, screening at government health facility at all levels, training of ophthalmic assistant in taking fundus photographs using non-mediatic fundus camera, use of teleophthalmology, use of online-based softwares and Android applications for data entry, storage and processing, and proper referral system and awareness about diabetes mellitus and diabetic retinopathy among the non-diabetics. Their family and community, with the help of trained ASHA, will make the screening for DR robust and effective in the rural population of India. In order to tackle the rising problem of avoidable blindness due to DR in developing country like India, such methodology can be streamlined on a larger scale. Thank you.
You know, the effort is really tremendous.
Yes, sir.
But what you really need to do is present some data actually. And
Okay.
there are many things that you could have assessed the awareness of the ASHA levels, efficacy of
Yes,
the
yes.
patient, efficacy of awareness, efficacy of the quality of photographs,
Yes, sir.
You need to present some data. You need to make it into a research paper. What you've done is you just described the process that was happening,
Okay.
which is surely commendable.
Yes.
No, really.
Okay. Chalo. Thank you, sir.
Thank you. The next paper is by Dr. Ishita Bajaj. She here? Yeah. To study the role of hematological biomarkers in type 2 diabetes patients with diabetic retinopathy. Okay. And no, come, please come. And yeah. You're the first speaker. What's your name? And where is the timer, audiovisual team? You are the timer. Okay. So how do we know? Your membership number is this, no? 121771. So you're not.
So you are a ratified member?
You just became a member. Okay. Okay. So non-ratified. Go ahead. Start.
Good afternoon, faculty and everyone present here. My topic is to study the role of hematological biomarkers in type 2 diabetes patients with diabetic retinopathy. Diabetic retinopathy is the most common and severe microvascular complication of diabetes mellitus, and a leading cause of irreversible blindness. The prevalence of diabetic retinopathy is expected to double by 2030. Diabetic retinopathy is a multifactorial disease, and extensive research has increased our understanding of the pathophysiology of the disease, leading to newer treatment options for diabetic retinopathy. But in spite of the intensive screening programs, diabetic retinopathy or its complication is still not prevented and also not accessible to everybody. Other than the major known risk factors for diabetic retinopathy, recently the role of insulin resistance has been studied, which is a multi-system disorder that is associated with multiple metabolic and cellular alterations, leading to an abnormal insulin activation. It is present in most of the patients of diabetes mellitus, and it leads to other macrovascular diseases also, one of which is a prothrombotic state that promotes thrombosis or retards thrombolysis, resulting in an increased platelet function and the microvascular complication. Therefore, based on this, we have studied the role of various platelet indices to predict their role in diabetic retinopathy. The study was conducted on 99 diabetic patients and 33 controls, and after consent and ethical clearance, a detailed systemic and ocular history with complete ocular examination was done. The inclusion criteria included patients of diabetes type 2, aged 20 to 75 years, and exclusion criteria had patients with hemoglobinopathies, thrombocytopenia, platelet disorders, acute and chronic inflammatory conditions, any media opacities hindering our diagnosis and classification, and patients on antiplatelet drugs because these change the platelet volume values, and unwilling and uncooperative patients. The controls were age and gender matched without any family history of diabetes and with normal blood sugar and HbA1c values. 3 groups were studied, with Group A, diabetes with retinopathy, 66 patients. Group B was diabetics without retinopathy, 33 patients. And Group C was healthy controls. The retinopathy group was further divided on the basis of severity of retinopathy. The platelet indices that we studied were mean platelet volume, platelet distribution width, platelet count, and platelet crit. We had to collect 2 ml of blood sample in an EDTA container in sitting position from the antecubital vein. It was processed in the automated cell counter within 2 hours of collection and noted thereafter. The normal values were taken as less than 10 femtoliter for mean platelet volume, less than 15% for platelet distribution width. Platelet count was taken as 1.5 to 4.5 lakhs per ml as normal, and platelet crit 0.22 to 0.24%. And appropriate statistical tests were applied. We found no significant difference in the age group of the 3 groups, but the mean duration of diabetes in Group A and Group B was significantly different, with a p-value of less than 0.001. The mean platelet volume was the highest. The mean value was the highest in Group A, that is diabetics with retinopathy, and the least in Group C. The mean MPV values also showed an increasing trend in the retinopathy group, with the maximum value in proliferative retinopathy group and least in mild NPDR group. Percentage of patients with high MPV values was around 82.7 in Group A, 16.9 in Group B, and 0.4 in the healthy controls. Around 88% in proliferative retinopathy group had high MPV values, where it was 87.5 in severe, 61% in moderate, and 50% in mild NPDR group. We also found a 6.13-fold increase in the risk of retinopathy development with increased MPV values with logistic regression analysis. Also, the increase in the MPV values had no relation with the duration and control of diabetes. A similar trend was seen in platelet distribution width, where the values were highest in Group A and least in Group C. There was also an increasing trend of rising mean PDW values, highest in PDR and lowest in mild NPDR group. Also, 97% of the patients from Group A had high PDW values, where it was only 0.2% in Group C. Here also, there was no relation with duration and control of diabetes. Other platelet indices were not statistically significant, although we found an increasing trend from controls to diabetic without retinopathy, and was highest in with retinopathy, but it was not statistically significant. Therefore, in our study, the mean MPV and PDW values were higher in retinopathy group as compared to non-retinopathy and least in controls. Also, it increased with severity of retinopathy. But the previous studies which were conducted were controversial, as some found similar results at our studies. but others found no significant relationship between the vascular complications and MPV and PDW values in diabetes mellitus. Also, the 6.13-fold increase in the risk of retinopathy that we found in our study was reported to be only 1.4-fold in the West in a previous study conducted. And also the duration and control were not found to be confounding factors in our study, and this has not been reported in any other previous study. In conclusion, it is suggested that the platelet indices be routinely done in diabetic workup, as these may help in identifying patients likely to have retinopathy. Also, these are conveniently obtained from automated cell counters, as diabetic retinopathy detected early will help in reducing the morbidity, blindness, and healthcare costs in these patients. However, a large diabetic population needs to be screened to confirm our findings. Thank you.
But is what your findings are in keeping with the line of other papers and other research?
Some papers, yes, sir.
MPV and
Yes, sir.
PW. So how strong do you think is the predictive value as a biomarker in the MPV for progression of?
So we found a very strong prediction of MPV and PDW in diabetic retinopathy patients and also with severity of retinopathy.
Predictive value for onset of retinopathy?
So for onset of retinopathy, because we had patients with 3 months of diabetes to 25 years of diabetes, we did not follow them up in the pre-diabetic region and then onset of diabetes. So that was missing.
Were the patients of nephropathy also included?
Yes, sir, they were included.
Subgroup analysis.
Sir, we did not show nephropathy plus retinopathy together. I had done, it was my thesis topic, so I had done it for nephropathy also, but I couldn't correlate it in this paper. So.
And any idea how type 1 patients would behave?
So type 1 has a higher incidence, but I had taken only type 2 diabetic patients. So I had not screened for type 1 and type 2 together.
I just want to ask you, this was a cross-section study.
Yes, sir.
It's a little hard to use these as parameters that can predict the development of subject. For that, you need to
Follow up, yes, sir.
these values and then
Again,
and see that
yes.
which of those patients with somewhat higher values, and then that is it just an association of the stages of retinopathy with these parameters,
Yes, sir.
or are these parameters actually predicting the development of subject?
So for prediction and their increase with retinopathy, we need to follow up, but this was a cross-section study, so we had just taken a one-time value of the MPV and PDW, and obviously for that we need to follow up also as the retinopathy increased. Yes, sir. Thank you.
Thank you. I next call upon Dr. Kumar, and he's going to present his paper on simultaneous acute bilateral BRVO, etiological associations and clinical outcomes.
Good afternoon, everybody. My paper is about simultaneous acute bilateral BRVO, possible causative associations, I wouldn't say etiologic, possible causative associations and clinical outcomes. The aim is to describe the possible causative associations and the pattern of complications in bilateral simultaneous branch retinal vein occlusions. We had 22 subjects in the age group between 28 and 76 years, 14 men and 8 women. It was a prospective observational case series. And the veins involved were either the main vein, branch vein, or a tributary vein. 12 patients had pre-existing diabetes mellitus and hypertension at presentation, all presented with sudden onset of visual symptoms, blurring of 1 to 8 days duration. And the features of vein occlusion were obvious, in branch retinal vein occlusion were obvious in all these patients. It involved the arteriovenous crossing in all but 2 patients where it was along the length of the vein. Multiple BRVOs were seen in 1 patient. To authenticate the fact that these photographs that I will be showing are of the same patient, the optic disc configuration, the congruity of the disc, as well as the age of the hemorrhage, the appearance of the retinal bleed in both eyes, they authenticate this fact. Exclusion criteria: those who had old BRVO in one eye, or sequential BRVO in the 2 eyes of more than 1 month duration, or patients with CRVO or hemi-CRVO in the other eye were not included in this group. Now, a routine workup for all retinal vein occlusions, as is normally done, was undertaken even in patients who were young. it is generally thought that young patients have other etiologies, and diabetes and hypertension are not so common in the younger age groups, and that they have other thrombophilia states. But we did find that many youngsters in our group also had undetected hypertension. One lady was on OCP. After history and review of systems by an internist, additional tests were ordered in a tailored manner, and these included homocysteine, ANA, chest X-ray, ACE levels, APLA, HIV status, hepatitis B and C, and serum protein electrophoresis as well. Coming to the results, hitherto unknown occult predisposing factors were found in 10 patients, and open-angle glaucoma, which was not diagnosed up till that point of time that the patient presented to us, was diagnosed in 3 patients for the first time. The commonest underlying cause was hyperhomocysteinemia. One patient had an ANA positive, and that was again confirmed by a ANA profile, and APLA was also positive in this patient. Leukemia was detected for the first time in one patient, sarcoid in one, renal artery stenosis in a young undiagnosed hypertensive, and hyperviscosity from polycythemia and thrombocytosis was detected in one patient each. Now these are some pictures of the patients that we saw. This was a patient who had bilateral vein occlusion, but not at an AV crossing, but along the segment, along the length of the vein with perivascular exudates. And this patient had sarcoidosis, and with treatment of the systemic condition, the fundus findings abated, but later he needed laser for the peripheral neovascularization that he developed in the left eye. These are more photographs of patients who had bilateral simultaneous branch retinal vein occlusions. This was a patient who had multiple branch retinal vein occlusions in both the eyes, and he was diagnosed to have CML for the first time. As I alluded to in my results column, there was more than a 50% incidence of neovascularization in either of these eyes, and this was one such patient where the left eye had extensive capillary dropout in the upper temporal quadrant that stabilized with laser treatment. More pictures of patients with bilateral BRVO. This was the lady with SLE positive findings. She had a nasal BRVO in the right eye, and BRVO along the upper fundus in the left eye, not involving the macula. And she had extensive capillary dropout areas, and she was referred to an internist for anticoagulation. More pictures again. This was a patient with thrombocytosis who presented with bilateral vein occlusions, and even as we were trying to get her investigated, she developed more hemorrhages in the superior fundus of the right eye, and she needed laser photocoagulation for the extensive capillary non-perfusion in the new vessels. These are the last set of pictures of a patient who had bilateral vein occlusions, and this was a patient who had polycythemia. The average follow-up was about 4 years, with a range from 5 months to 6 years. As I said, 8 patients developed new vessels in one or the other eye, so a higher incidence of new vessels because a common underlying factor was found in nearly 50% of these patients. 12 patients developed recalcitrant macular edema stubborn to various treatment modalities, and anti-glaucoma treatment had to be started in the 3 patients who were diagnosed to have OAG. Systemic anticoagulation in the SLE patient and follow-up with hemato-oncologist in the others was advised. So in conclusion, acute simultaneous BRVO needs a more comprehensive evaluation and not necessarily restricted to the microvascular group that we've seen in elderly patients, and OAG is not to be missed, and complications either in the form of new vessels or recalcitrant macular edema, possibly because there is a strong underlying causative mechanism operating, complications are more likely to happen in one or the other, in either of the 2 eyes. And additional relevant tests as dictated by systemic history and the review of systems is necessary. Serious and potentially life-threatening conditions were found in our group in nearly 50%, slightly less than 50%, and therefore it mandates aggressive search for additional causes in these groups of patients. Thank you very much for your patient hearing.
Yeah, you covered very well the topic, but how much percentage was the, did you investigate for factor 5 or other
We didn't go through the thrombophilia full profile because the physician felt that since these patients did not have any family or personal history of thrombosis, that particular, the factor laid, protein C, protein S, antithrombin, the whole thrombophilia profile would be needed when there's a strong personal or a family history of thrombosis. and otherwise, or recurrent abortions in case of women. So only then would it be mandated, otherwise it will be too much of an overkill and the costs are quite prohibitive.
So, the one referred for anti-coagulation treatment.
She had SLE and APLA.
Very nicely documented and great fundus pictures and FFA pictures. So, one of the prognostic markers of BRVO is the macular ischemia. That tells how much vision will come back. You thought that in this, patient subtype with bilateral BRVOs with these systemic problems, there is higher chance of macular ischemia?
I will have to look into that. I haven't looked into that. But quite surprisingly, as you could see, many of these patients, the vein occlusion was not really involving the macula. The hemorrhages were in a part of the fundus away from the macula without much of a hemorrhage or edema in the macula. But that point I haven't assessed. The macular ischemia, I'll have to look. I'll go back and look at that. Thank you.
Sir, this many bilateral cases during a period of how many years, sir?
This is now 12 years.
12 years. Oh.
I had 22, I think, if I remember right. I'll just 22, yeah. 14 men and 22, yeah, 22 subjects.
Thank you, sir.
Thank you.
Thank you, sir. Next, we have the keynote address by Dr. Rema Mohan. Is she here? Yeah. A keynote address on diabetic macular edema or masquerade. No, sorry. This is the Rema Mohan Award. I'm so my apologies. It's by Dr. Ashish. Is he here? Dr. Ashish. Then there is a best paper from Rajasthan Ophthalmology Society, study of screening of ROP in high-risk infant, Dr. Rohini Sharma. She's also not there. So then we'll go ahead with the next free paper. That's by Dr. Atul Sonawne. Please come. And it's on a 2-minute rupees 200 smartphone fundus camera for every eye care professional. Where is our timer? Our timer girl has gone. We'll keep the time.
Good morning, good afternoon, faculty and friends. The title of my presentation is a 2-minute rupees 200 smartphone based fundus camera for every eye care professional. Traditional fundus cameras offer good quality images but are bulky, office based and costly. There are commercially available smartphone based fundus cameras as Mi RedCam and do it yourself smartphone based fundus cameras. Here I would like to present a novel method of preparing a do-it-yourself smartphone-based fundus camera adapter for retinal imaging and photography. The assembly of do-it-yourself smartphone-based fundus camera. For this, a selfie stick and a car mobile holder is used. The mobile holding unit of the car mobile holder is disengaged from the main body of the selfie stick by unscrewing it. The mobile holding unit of the selfie stick is disengaged from the main body of the selfie stick by unscrewing it at this part. Then a groove is made in the mobile holding unit of the selfie stick with a hacksaw blade. The main body of the car mobile holder is then engaged in the groove made in the mobile holding unit of the selfie stick. The mobile phone is firmly attached to one end of this device by suction mechanism of the car mobile holder. A 20D or a 28D lens is firmly held in the mobile holding unit of the selfie stick attached to the other end of this device. Then assembly of the slit lamp mount. For this 16 mm length ice tongue used for holding ice cubes and a T-spanner used by two-wheeler mechanics is used. The ice tongue is joined at 90 degree to the T-spanner at one end and the car mobile holder at the other end. The device is mounted on the slit lamp by one end of the T. Next, the Ullman Indirect app is downloaded from the App Store and used along with iPhone to examine the retina. This app helps in controlling illumination and exposure during image capture. It also enables to keep light continuously on during capture of retinal images. and it also has the feature for rotating the captured images laterally and vertically to give the right orientation of captured retinal images. It is possible to do indirect ophthalmoscopy with this device by holding this device in hands with the 20 D lens directed towards the eye, and a two-dimensional image of retina is viewed on the screen of the mobile phone. For photography of the central retina, the device is first mounted on the slit lamp, and the patient is asked to rest his chin and forehead on the slit lamp. Then, as we perform the 90D examination, the 20D lens is centered on the pupil close to the examining eye and gradually brought away from the patient's eye till a perfectly focused image is seen on the screen of the mobile phone in the Ullmann Indirect Photography app. Now the photos are shot in the photo burst mode of the app, and best photos captured can be selected and saved in gallery of the mobile phone. The images of peripheral retina can be captured by examining the patient in reclining position in chair unit and shooting the images in video photo burst mode of the Ullmann Indirect app. Good images were captured by following the basic principles of fundus photography, that is, adequate illumination and exposure was achieved with the Ullmann Indirect app for retinal photography. Avoidance of movement blur was achieved by asking the patient to rest his chin on the chin rest of the slit lamp, and stabilization of the mobile phone by attaching the device to the slit lamp attachment. These are some of the photos captured with this device. The images captured can be edited in Adobe Photoshop app for preparing textbook like circular images, making a collage of pictures and adding text. This is a picture of a patient with ARMD with geographical atrophy. Then this is a patient of hypertensive retinopathy with exudation. This is a case of optic disc hypoplasia with classical double ring sign. This is a case of serpiginous choroiditis. This was a patient of CRVO, which we followed for 4 weeks. This was a picture after 1 week. This we had given, patient was pseudophakic, and we had given intravitreal tricot for the patient. He was not affording anti-VEGFs. This is a 3 weeks follow-up of the same patient. This is a 4 weeks follow-up, and the image has been laterally and vertically inverted for the right orientation. This is a 5 weeks follow-up of the same patient, and the hemorrhages have been resolved. This is a collage made of the all the different weeks presentation in the Adobe Photoshop app. This is a patient of macular scar due to toxoplasma infection. This is a case of PDR and a diabetic macular edema. The application of this device in day-to-day practice is fundus photography of the central and peripheral retina for documentation and patient counseling, for performing two-dimensional indirect ophthalmoscopy with the image viewed on the screen of the smartphone, and it can be used in telemedicine program, screening programs for diabetic retinopathy. Image captured on the field is transferred via the internet to the reading centers. Thank you.
Thank you, Dr. Atul.
Okay.
Just one question I have. We have, in the last couple of years, we've seen so many of these smartphone-based apps and all these gadgets come up. So what is the USP of your device? How is there, you have one or two points how it is different from the others?
It can be made in a short time, means literally 5 minutes, and with a mobile phone, selfie stick and car mobile holder, which is easily available to anyone, and the stability of the mobile phone and the lens is achieved perfectly with this device, so there is no movement blur.
Okay, thank you. The next presenter is Dr. Vikas Ambia, and he is going to present on role of 532 nanometer subthreshold micropulse laser in non-resolving CSCR with subfoveal leaks.
Good afternoon, everyone. So the title of my study is the role of 532 nanometer subthreshold micropulse laser in central serous choroiditis, which is non-resolving, with subfoveal leak on FFA. So we have a lot of studies on subthreshold micropulse laser being used in CSCR, but if you see, most of these studies are using 810 nanometers diode laser, and a few studies using 577 nanometers yellow laser. We found only one study which is specifically targeted on CSCR having subfoveal leaks on FFA, and this study has used 577 nanometers yellow laser. Now, another option in these cases would be doing a PDT, which is an expensive option for the patient. So with this background in mind, we went ahead with the aim of studying the role of 532 nanometers subthreshold micropulse laser in non-resolving CSER, having a subfoveal leak on FFA. It was a prospective interventional study in which we included patients more than 18 years of age, symptomatic for at least 3 months of duration, having subfoveal fluid on OCT, and having a focal subfoveal leak on FFA. We excluded all the patients who had chronic CSER in the form of RPE changes, patients with the past history of treatment for CSER, having multiple leaks on FFA, patients having other vitreoretinal disorders currently or in the past. We also excluded patients who had undergone any intraocular procedure in the past 6 months, who were currently or in the past on steroid therapy, who had an opaque media to compromise the quality of imaging, and patients having a high refractive error. So what we did is we used a 5% we used Quantal medical laser, 532 nanometers with a duty cycle of 5% and a pulse duration of 200 milliseconds. So gave a test burn of 100 microns outside the vascular arcades using this to titrate the threshold power, and we used a grid of 5 by 5 confluent laser spots with no spacing, with zero spacing. We used 20% of the threshold power to give the burns. So we targeted this grid of laser spots on the area of the focal leak which was subfoveal in all these cases. As you can see in this is just a schematic diagram. So the outcome measures, the primary outcome measures were the change in the visual acuity, the change in contrast sensitivity. The secondary outcome measures were resolution of the neurosensory defect, detachment, and to find any adverse effects of the laser. All the eyes which showed no increase, which showed no change in the height of NSD or showed an increase in the height of NSD were subjected to a rescue laser with the same settings as in the primary treatment. So this is one prototype case, 35 years old male with a vision of 618. This is the subfoveal leak which we see on FFA. We did laser. This is the pre-laser OCT. This is 1 month post OCT. We don't see any changes on OCT at the level of RP or ISOS junction. This is the autofluorescence before laser. This is the autofluorescence. We can see the RP changes which are pre-existing before laser was done, and the autofluorescence 6 months later with again no changes. So we had 23 eyes of 21 males whom we treated with a mean age of 37.09 years and a test duration with a symptom duration of mean duration of 4.48 months. And the laser power which we used was in the range of 140 to 240 milliwatts. This is the trend in the improvement in visual acuity. We see there was a significant improvement at every visit, at 1 month, 3 months, and at 6 months. There was an improvement in contrast sensitivity again, which was statistically significant. This was measured only at the end of 6 months after the laser. We can see that there was a continuous resolution of neurosensory detachment, and you can see the curve is steepest in the initial first month, when the maximum effect was seen after doing the subthreshold micropulse laser, and the corresponding improvement in the central macular thickness also. So when we see the number of eyes which had a complete resolution of subretinal fluid, it was 9 out of 23 eyes at 1 month, improving to 12 at 3 months, and 16 out of 23 at 6 months. So if I show you the data set of individual eyes, 2 of the eyes did not show any response to subthreshold micropulse laser at the end of 3 months, and so they were subjected to rescue laser. But these eyes again continued to have a persistent fluid, so they were ultimately at the end of 6 months subjected to photodynamic therapy. There were another 2 eyes who initially showed a good response, so we did not give them rescue laser, but at the end of 6 months they had persistent fluid, so at the end of 6 months they were subjected to again repeat laser. These 4 eyes are still under follow-up. As far as the safety concerns go, no laser spots was visualized at the end of 6 months by biomicroscopy or on OCT or on autofluorescence. None of the patients had any complaints like a positive scotoma or any other complaint related to the procedure. So to conclude, 532 nanometers subthreshold micropulse laser is safe and effective treatment for persistent CSE with subfoveal leak on FFA. There may be a need to repeat the micropulse laser in cases who do not respond in the first sitting. But definitely, since the number of eyes in our situation is a little less, it's 23, but then the cases with subfoveal leak is not very common. So, we have a follow-up which is still being carried on, so maybe a longer follow-up would give us a more definite conclusion from our study. Thank you.
Thank you, thank you. So one or two quick points.
Sir.
You said you tested for adverse effects.
Yes, sir.
So what were the tests involved in the FFA, SDOCT, autofluorescence?
Yes, sir.
No microperimetry?
Yes, sir. I didn't have a microperimetry, so that thing was not available for the study.
And
that was the limitation, sir.
Yeah, and what are the indications? You said for recurrence.
The indication was only for,
Let me complete it.
Sir.
For recurrence, 2 of the patients were subjected to PDT, right?
Yes, sir.
Why PDT and why not repeat? What made you think?
Because they did not respond to the rescue laser. Rescue.
How
there
long
was
did you wait? 3 months.
3 months. We gave rescue laser after 3 months.
Did you assess that the reason for durations? Because sometimes it takes 3 months is just a
Yes.
cut-off point.
Yes.
But sometimes depending on the volume, initial volume of the
Yes, sir. So we were basically assessing the change in the height of NSD. If we saw that the subretinal fluid was resolving, then irrespective of the months, we did not give a laser, sir, because it is responding on its own or to laser.
because PDT is known to have a lot of RP atrophic
Yes.
just changes in long-term follow-up.
So one question.
So the ones-
have
sorry.
you done OCT angiography in these cases of chronic
OCT
CSR?
angiography was not available in my institute.
Why
sir.
I'm asking, lot of cases of which we think are chronic CSR, on OCT angiography they may show a pachychoroid
Pachychoroid.
pattern. Yeah, so
Yes, sir.
in
That
those
was not-
cases,
yes, sir.
anti-VEGFs may be a better
Yes,
option.
that was not an alternative for me.
Okay, thank you.
Thank you.
Our next paper is by Dr. Pallavi Sarate, and she's going to present on OCT biomarkers in prediction of visual acuity in diabetic macular edema treated with bevacizumab.
Good afternoon, everyone. I'm Dr. Pallavi, and today I'm going to talk about role of OCT biomarkers in prediction of visual acuity in DME patients treated with bevacizumab. As we all know, that OCT does not only help us for diagnosing the condition of DME, but it also helps us for monitoring the treatment response as well as to decide which treatment we need to give. So the characteristics on this OCT can be used as biomarkers which can help us in predicting results in terms of visual outcome in these patients. So the aim of our study was to determine which are these characteristic OCT features which can act as biomarkers and to evaluate their potential to predict visual outcome in DME patients treated with bevacizumab. So it was a retrospective study carried out between 2014 to 18. All type 2 DME patient treatment naive eyes only were included in this study. 42 eyes were studied. CME with more than 300 microns of thickness was included in the study. Any patient who has already undergone treatment or who has any ocular disease were excluded. Zeiss Cirrus OCT was used, and basically 3 OCT scans were taken, one passing through the fovea, second 500 microns superior and 500 microns inferior to the fovea. So best corrected visual acuity was evaluated at baseline, 6 weeks post-injection and 3 months post-injection. So the results were evaluated after 6 weeks, and the results were evaluated and compared with the best corrected visual acuity gain, more than 10 letters, less than 9 or more than 10 letters of loss. So the factors which were studied were subretinal fluid, outer and inner nuclear layer cyst, which were not seen to have any effect on the visual acuity. However, factors such as subfoveal external limiting membrane continuity, which was again divided into completely continuous, partly disrupted and completely disrupted, subfoveal ellipsoid zone continuity, subfoveal photoreceptor outer segment zone thickness, and high reflective foci location. So these last 4 markers were seen to have better visual outcome, and they were found to have statistical significance. Similar results were found even 3 months post bevacizumab. So what exactly are these biomarkers? So biomarker is a term which is merged from biological marker. So these are basically the signs which objectively indicate state of or health or well-being of the tissue or the person. So it can be either anatomical or biochemical, or it can be an imaging feature. So OCT is an imaging biomarker which can tell us about retinal structural alteration, that is thickness or thinning of the retina, or retinal ultrastructural alterations, that is external limiting membrane continuity or low refractive foci in the retina, and third is the vitreoretinal interface endpoints. So the first point which was studied was subretinal fluid. In our study, we did not find any statistical association or significant improvement in visual acuity in patients with or without subretinal fluid. However, there is a study by Rafe Sophie which showed that patients with subretinal fluid who were treated with bevacizumab, they had very good visual outcome as compared to sham treated patients. So maybe because in sham patients the fluid remained there for very long time, and thus persistent SRF caused deterioration of visual field. However, ranibizumab caused very fast resolution of the fluid. Outer nuclear layer and inner nuclear layer were not found to have any significant association in our study. However, it's not only about the number of cysts or location of cysts, but what we hypothesize is that even the chronicity of the disease and how much is the tissue remaining behind can also determine visual outcome of the patient. So for example, even after giving injection, if edema resolves, and if as in we can see in the second picture, the tissue remaining is very less, so this patient will not have very good visual outcome. Now talking about external limiting membrane continuity, we know that external limiting membrane is actually the plexus between the Mueller cells and the photoreceptor. So it forms the third blood retinal barrier, and it prevents to and fro passage of fluid. So obviously whenever this external limiting membrane is disrupted, obviously fluid is going to go inside the retina, or it can go into the outer retinal layer. Therefore, completely continuous external limiting membrane patients were found to have very good visual outcome. Now ellipsoid zone. Ellipsoid zone contains maximum number of mitochondria, so it is the powerhouse of photoreceptors. Therefore, any damage to this ellipsoid zone will lead to significant deterioration of vision in the patient. So this it can be seen, ellipsoid zone disruption can be seen either because of actual anatomical absence of ellipsoid zone or because of decreased reflectivity of the ellipsoid zone. So obviously completely continuous ellipsoid zone was found to have very good visual outcome, which was statistically significant. Similar results were seen in the paper published by Fadikar et al., where they showed that disrupted outer retinal layers were associated with poor visual outcome. This can explain, even after giving bevacizumab or any anti-VEGF, even if the edema resolves, some patients don't get very good visual acuity. So that can be because of already disrupted outer retinal layers that can lead to poor visual outcomes in patient. And coming to photoreceptor outer segment thickness, which is around 35 to 40 microns. So all patients who had good photoreceptor thickness were found to have statistically significant improvement in the visual acuity, and those who had thinning or atrophy were found to have poor visual outcome. Now high reflective foci were actually thought to be because of only lipoprotein extravasation, but by this study, study by Vujosevic showed
Pallavi, your
that
time is up.
Yeah, okay, sir.
Just conclude.
Yeah, so limitation of the study were a lack of control groups, small sample size, and angiography was not done, therefore ischemia could not be noted. So to conclude, OCT biomarkers help in diagnosis, to grade severity of the disease, and also to predict prognosis of the patients. So continuity of external limiting membrane, integrity of ellipsoid zone, thickness of PROS, and high reflective foci were found to be significant biological biomarkers in our study. Chronicity of disease, tissue loss in outer retina, and ischemia can lead to poor visual outcome instead of having very good outcome, anatomical outcome after giving injection. Therefore, future prospective studies should be done. Thank you so much.
Just one. What's your thought about the concept of DRIL, DRIL?
Yeah, so there is a recent paper in 2019 where they have shown that even the disrupted inner retinal layers are found to are very important biomarkers, and along with DRIL, even the retinal thickness, that is outer retinal thickness and low reflective foci, these are three more important markers which are considered to be very important in predicting visual outcomes.
You didn't look for drill in your study?
Ha sir? No sir, we didn't check.
So I just want to ask you that we're talking of visual outcome when we treat these patients, isn't it, with anti-VEGFs? Because they come with edema, diabetic macular edema, isn't it?
Yes sir.
So, so what you're saying essentially is that when these biomarkers are affected, then the edema doesn't subside, or the edema does subside, or
No
what,
sir.
What conclusion do you draw clinically actually?
No, these biomarkers are important to know about how would be the prognosis of the patient, but along with that, the other markers such as ischemia or chronicity of disease, they should be also be considered.
I just reiterate what sir was trying to make a point, was that in some cases, what he means is, even though there is resolution of the diabetic macular edema, but that is not translated into improvement in visual acuity.
Yeah.
To find out what are the reasons for that phenomenon happening,
Yeah.
you need very good biomarkers, which can serve as surrogate visual acuity indicators.
Exactly, sir.
Among them, you have to choose which are the ones which are best.
Yeah, so basically the outer retinal layer biomarkers, that is external limiting membrane, ellipsoid zone integrity, these are the important biomarkers which should be considered. Thank you, sir.
Thank you. We have our last presenter for this session, Dr. Apurva. Yes. Yeah? And she's going to present on a novel angio-OCT finding. Oh, okay. A previous presenter has also come. So then this is the last but one presentation. So Dr. Apurva is going to present on a novel angio-OCT finding at the vitreoretinal interface in macular telangiectasia type 2.
Thank you, sir. I acknowledge my co-authors and have no financial interests. So I'm going to report a novel finding of epiretinal neovascularization in MACTEL and describe its clinical and multimodal imaging features. So we know MACTEL2 is a neurodegenerative disorder. There are various staging systems in place: clinical, OCT, autofluorescence, FFA and ICG. Octa has recently given us insights about the deeper capillary plexus as well. So I conducted a retrospective chart review in diagnosed patients of MACTEL type 2 who came to our clinic from 2nd Jan 2017 to April 2018. We did the clinical and the multimodal examination in all of these patients using the Heidelberg platform. We did the OCT with a 20 degrees angle, and the distance between the two scans was 30 microns, and an ERNM or an ERN was described as a thin membrane on the SD-OCT. So an Octa was also obtained in all these patients in a 3x3 scan, and the distance was only 11 microns between each scan, and a vascular membrane at the vitreoretinal interface was described as an epiretinal neovascular membrane. In addition, we also saw a hyperreflective structure or a flow signal which suggested intraretinal communications. So we saw 68 eyes of 34 patients of MACTEL in total, of which we saw that 7 eyes of 4 patients were identified to have an ERNM, of which we had 2 females and 2 males with a mean age of 56 years. Of these patients, only 1 patient was diabetic. So this is the first case. She's a 48-year-old female with diminished vision for near. She's a diabetic since 3 years. She had 6/9 and N8 vision in both eyes. You can see that there is this typical macular telangiectasia pigment and background diabetic retinopathy in this patient. So there was this lumpy membrane atop this intraretinal pigment in the right eye, and the FFA showed the typical MACTEL staining in the late frames. We did a wide-angle FFA to rule out any extensive capillary non-perfusion or other PDR features. So this is the right eye OCTA, where we were surprised to see this big vascular network, where we delimited it to the VR interface. Next is the left eye. I'm sorry, this is again the right eye. This is a hyperreflective structure that is shown as a vascular communication. This is the ICGA, where we didn't find any CNVM. Of course, it was blocked by pigment. This is the left eye, where we see again a very, very thin membrane. Left eye FFA, ICG. Coming to the Octa, you can see again that there is a vascular structure which is best seen on the vitreoretinal interface. This is case 2. This is a unilateral ERNM. You can see this thick membrane on top of the retina. The other eye does not have this membrane. This is the diffuse FFA leakage. And when we see this membrane, it is actually seen also here because of a projection artifact. But when you delineate it, it is actually best seen on the VR interface. So this is case 3, which has bilateral Mactel type 2 with bilateral asteroid hyalosis. This is the FAF with stage 3 FAF, and this is the FFA with the circumferential staining. So I actually have a video FFA of this patient where you see that the early frames show that there is early filling of this ERNM, and if we can bear in mind the shape of this filling of this network, which is in a sleeping Y position, if you just remember this shape, you can actually see it on the OCTA also in a Y shape, which is all the more reason why it is on the VR interface, because there's a tag that is actually extending into the vitreous. Case 4 is again bilateral pigment in a 60-year-old gentleman. This is the multicolor image of this patient. So this particular case had a very thin wispy membrane on top, which was again an ERNM. And if you see, this is the OCTA of this patient, which shows 2 segmented ERNMs corresponding to the fragmented ERNMs on the OCT as well. So this is the wispiest membrane in my series of patients. We have one paper, one report which came out in 2014 of one case of ERM with Mactel. OCTA was not done in this case. In our cases, ERNM, like I call it, has a communication with an intraretinal hyperreflective structure, suggesting that maybe the retina is becoming too thin and leading to bearing of the abnormal capillaries of the superficial plexus itself on the retinal surface, or like CNVM, ERNM is a distinct endpoint of Mactel associated neovascularization. There were some common features associated with all these ERNMs in this series. All of them had pigment. The CNVM also occurs after the stage of pigment, like we know in the clinical staging. We wonder if the superficially migrated pigment incites ERNM instead of a CNVM. Remarkably, in all my cases, there were no empty spaces, ILM drape sign, or a lamellar macular hole that is typical of Mactel 2. So differential diagnosis that comes to mind, especially in diabetic retinopathy setting, is a foveal neovascularization. But there was, in our series, there was only one diabetic patient and she didn't have PDR. Another differential is a lamellar hole epiretinal proliferation, considering Mactel also has LMH, but I have imaged 2 cases of LHEP and it is not vascular. So ERNM does cause a projection artifact which is distinct from the dragged vascular complex of Mactel. Should we consider it as a distinct end-stage neovascularization like SRNVM? Should we treat it with anti-VEGF? And it is easy to monitor response also because of OCTA. So to conclude, this is a novel entity. Small sample size is a limitation. We recommend that all epimacular membranes be multimodally imaged, and it may represent a hitherto unknown form of proliferative Mactel like SRNVMs.
Very good presentation.
Thank you, sir.
But I am particularly baffled by this finding, because Spade and many other people have showed NV occurring at a deeper level, DCP level.
Yes.
So it's a deep thing which is occurring. So, if you are very sure that it's not an artifact, and by using all possible algorithms, I'm not aware of all that, but superficial neovascularization Mactel is either it's unique or something is baffling.
So one particular artifact that comes to mind is a projection artifact. But a projection artifact classically, sir, has to project to a deeper level. So I am saying this is actually a superficial structure. And in fact, no sir, there's no such thing. So in fact, these plexus, these ERNMs cast a projection artifact in the deeper layers where you may think it's actually a Mactel capillary plexus, but it's actually an ERNM projection artifact. So that's what I've highlighted.
One other thing that has to be very, very decisively decided, threadbare, whether these are neovascularization or just dilatations in the ERM.
Yes, sir.
Because ERM per se are known to leak on FFA, and ERM is known to leak because of capillary permeability being disrupted.
Yes, sir.
So are we really dealing with a neovascularization or is just a ERM?
So it's a membrane which is vascular. It's ultimately what we boil down to calling it. So since I've seen it for the first time, I took the liberty of naming it epiretinal neovascularization. If we follow them up, maybe we'll have a better term for it. I have one of my colleagues in Hyderabad who actually saw this after I presented, and in his case, this ERNM has bled. So which makes me wonder if these are not really as benign as they look. I'm sorry? Management. Yes, sir. So one particular distinct finding I saw was that there are no intraretinal spaces or empty spaces, drape sign or anything else. It's ultimately just profound retinal thinning and pigment. That is one. Second is these ERNMs, I have only one case, anecdotal case where it has bled. So I have a very short follow-up of these cases, sir, maybe 4 or 5 months. I'll be following them up further to see the natural course of these ERNMs.
I'm sorry, I didn't notice, but in which layer was it visible in the OCT angiography?
So the epiretinal surface, sir.
No, the neovascularization. Only
Epiretinal
epiretinal.
surface, yes, sir.
So it's unlikely to be a CNVM because that
Of
would
course
be in
not,
the,
sir.
yeah, so it's unlikely.
Yes. Thank you. Thank you.
Thank you. We have a previous presenter, na, which a paper. Dr. Manpreet is here? Yeah. So you are going to present on quantitative and qualitative comparison of Whitefield OCT angiography and FFA in PDR.
Very good afternoon to all, and thank you, sir, for accommodating me now. Okay, so I'll be sharing this very preliminary study that we did using Whitefield OCT angiography montages at GEI Chandigarh. Financial disclosures, we are a part of ARI Network, which is an international collaboration by Zeiss on retinal imaging. Just to give you a brief background, we all know and understand the important role which is played by fluorescein angiography in our understanding and management of diabetic retinopathy. It picks up your microaneurysms, your intraretinal microvascular abnormalities, non-perfusion and leakage so well, but it still remains an invasive test with few very serious side effects. And so from the era of ETDRS, this 7 standard field capturing protocol has evolved, but even with the modern digital cameras, this remains a very difficult and cumbersome process for the technicians. Because of these many limitations of FFA, the quest for something new was always there, and then came these OCT angiographies. They allow the evaluation of retinal vascular network without the insertion of dye, and thus makes the process much simpler, but the main challenge was the limited field of view and lot of motion artifacts. And then came these wider fields with 12 mm montages, which are able to cover around 70 degrees to what 16 degrees was initially provided by the 6 mm scans. So thus we thought of evaluating these wide field 12 by 12 mm montage images with the traditional fundus fluorescein montages in patients with PDR, both qualitatively and quantitatively. And we hypothesized that non-invasive OCT angio wide field images will probably reveal a comparative information regarding neovascularization as compared to invasive fluoresceins. It was a retrospective observational case series of around 70 eyes of 42 consecutive diabetic patients with PDR, and all patients were imaged using the novel technique to create wide field OCT-A using 12 by 12 mm scans on a prototype software of Plex Elite. TopCon traditional fluorescein angiograms was performed in the same sitting, and features which were seen on montages were qualitatively compared to the traditional FFA image. And for quantitative analysis, we use the ImageJ software, which is publicly available. Images with poor signal strength and image artifacts were obviously excluded from the study, and both the investigations were performed in the same sitting. Now, 2 graders, they independently analyzed for the presence of neovascularization, and quantitative analysis, as I said, was done using ImageJ software. Now, the outline of retinal pathology was manually drawn, and the surface area was calculated in pixels. The pixel value which was generated on ImageJ software was further converted into micron values, with the assumption that the retinal vein diameter at its exit was around 125 microns. And coming to the results, we had 70 eyes, and the mean age was 56, with 56 years, and 56 males and 14 females. Average duration of diabetes was 15.5 years in them. NVD and NVE detection was comparable on these two different diagnostic modalities, and sensitivity was around, the sensitivity and specificity was 0.93 and 1 respectively. And strangely, we got a positive predictive value of 1, even though I must admit that it was really difficult to figure out to differentiate between IRMAs and NVE on an OCT angiography, and we at times has to rely on the OCT scan to look at the ILM interface. The quantitative analysis showed the total, the mean surface area of NVD and NVE was larger on an FFA, which is understandable comparing that we were measuring the leaky area, whereas on an OCTA these areas were a bit smaller because we were just marking the actual frond of NVE and NVD. These are just few clinical examples. Image on your left was of an FFA mosaic with clearly showed these multiple leaky areas due to underlying NVEs. The corresponding OCTA montage doesn't show leakage per se, but the florid NVEs are clearly seen as abnormal branching vessels in the superior and the inferior mid-periphery. Again, NVD and 5 NVEs were seen on the FFA image showing leakage. Corresponding OCTA image shows abnormal vascular franz with large areas of capillary non-perfusion seen infero-temporally as well. The strength for our study was that we had a very standardized image acquisition protocol. Limitations, a lot of image artifacts which sometimes create confusion. It was difficult to differentiate between IRMAs and NVEs at times, and we did not evaluate the far peripheral retina. To conclude, OCT angiography doesn't show leakage but can successfully delineate all areas of retinal neovascularization, and it probably may be useful as a routine surveillance in case there's any doubt for a PDR change in a diabetic retinopathy as a non-invasive test. Thank you.
Clarification which was I think mentioned at the end. It was a standard, FFA was not a standard 7S field
Yes,
montage.
yes, always, sir. Always.
Not the ultra wide field.
No,
You didn't go beyond
not the
that.
ultra wide field.
Because
Just
lot of
the TopCon traditional pictures.
yeah. But what I point out, there are a lot of 20-30% fresh areas are sometimes missed out on the periphery, which you obviously had said as a limitation of the study.
Limitation of our study.
Nothing.
Thank you. Thank you. So I think we are at the end. Has any of the other presenters come who were supposed to? There was a keynote address by Dr. Ashish, and there was a best state paper from Rajasthan, Dr. Rohini Sharma. Okay, then we conclude the session. I thank all my co-chair. Thank you.
Trained in Shankarnitra. From back 2005 to 7. You must be senior to me. I'm in Delhi, Center for
Oh, Center for
Where do you stay in Chennai?
I'm in Center campus.
Campus. Be here
So,
for
Munna Bande and all work.
my teacher's fine, and I missed her presentation. You must be filming it. What to do? There was no choice.
Yeah.
Somehow managed.